Okay, sorry for the brief technical delay. My name is Klaus Glüher. I come from Germany, and it's a wonderful experience to be back with friends here in Spain. First of all, I would like to thank the president of your society, Javier de Pino Monte, for inviting me this year. Again, I can say, so I've been here over the past years a couple times, so it's not just an honor, it's an honor to be here, but it's also a great pleasure to be back here. I remember wonderful meetings in Madrid, in Barcelona, and on Gran Canaria, and I have many, many good friends here in your society. And this morning, several of my friends actually go by the first name of Manuel. So first thing this morning, I met one of them, and he said, "You are one of us." So what could be better than that? So I'm very honored to be here. I'm pleased to be here, and I hope I can tell you something interesting that is going on in the area of imaging. We heard just from Luis Del Rio wonderful new developments in DEXA, but also in QCT. A lot has happened over recent years, and I would like to try to go over with this. So in the first half of my talk, I'll talk about some generic new developments with QCT, and then in the second part, I'll talk about one particular study where we use this technology quite advantageously. So I'll focus this morning on the spine. There are other applications at the hip, but time is short, so I will talk on the spine. And the regular technique that has been around for some time was single slice CT. Nowadays we have the spiral CT, and so we can much better, in much shorter time, evaluate the true 3D situation of the vertebra. And we calibrate this to bone mineral units, and we have different regions of interest. And one particular advantage is that we separately assess the changes in the cortical and the trabecular envelopes to see how our medications work, because they need to work in both compartments, and thus we need to talk about this. Now with QCT, there's one limitation. It has limited spatial resolution. And what is pointed out here on the screen is that if you have limited resolution, then any contrast will be sort of smeared out. It's the so-called partial volume effect. And I'd like to show you this in one example, and that's the vertebral cortical shell. This is an histological section, and on the right you see the numerical data. So by and large, the cortex of the vertebra is nothing much more than a little bit thicker trabecula. It's about 300 microns, 0.3 millimeters. But when you image this with QCT, and first look on the left here, in the bottom you see 3 millimeters, 10-fold higher apparent measurements. And also, when you look at the images, it looks like we have a thick cortex in there. This is an artifact of poor image resolution. To limit this, we have introduced the technique of high-resolution CT. It's far away from being perfect, but you see the cortical thickness on the same patient here went down from 3.3 millimeters to almost half of this, 1.9 millimeters. And still, we are not where we should be, but at least we're getting as far as we can with limited radiation dose. I'll come back to the radiation dose at the end. I think this is still very much acceptable where we are at this point. Now, we have developed this technique in our lab some years ago, and as you can see on the movie turning here, we get some internal structure. So that at that time was for the first time that we saw trabecular internally. It's a very coarse structure. Of course, the trabecula are also, like the cortex, much thinner in reality, but what we can measure actually quite well is the distance between trabecula. This is shown here. We get very good correlation between our measurements and a reference image there with much better resolution. The residual error is below 100 microns, and you know that separation is on the order of a millimeter or so. So that aspect of microstructure can be measured in vivo in the vertebra, and I think that is relevant for many applications. We have some bias still, the numbers are off, but still we get a measure. This can be applied to assess treatment effects. So we've done this, for example, with teriparatide you know it's a very potent drug, but you can appreciate this here also on the screen, showing the increases over 2 years in the internal structure of a patient in the Euroforce study. This is looking at the same thing with a more fancy 3D representation. So at the beginning, there's a fairly empty vertebral body, and it's filled up. BMD increases very substantially here. And to look at this in yet a different way, you can appreciate that we measure the internal structure, and we see the improvement. A patient who started out with a T-score of -2.7 ended up at -2 after 2 years with teriparatide treatment, and it's reflected in the structure that we see. Here are the numerical data. So you have here on the left, the DEXA increases on the order of, maybe 10%. QCT is almost double this. Then the trabecular lumbar or spacing, that's fairly similar measure. And the bone volume also increases even more because we have newly developed bone mineral matrix. So the volume is larger, and later then also the mineral catches up. When we apply this technique here, we can do one more thing, and that is finite element analysis. In a nutshell, without having time to go into detail, it's very difficult to measure the material properties of a complex study like the bone is. But what is much simpler is that you can divide the structure up in small little elements, cubes for example, and then you use the density measure of that cube, translate it into material properties, and then you put it all in the computer, and the computer lets all the little elements interact with each other. And then you see if you put a load, a simulation in the computer on that bone, you see the red areas here where the bone is under greatest strain, and that are the areas that are likely then to fracture. And you can apply this, for example, to the vertebra, of course, and you see where are the weak spots in the vertebral body. Okay, there have been many studies by different groups performed. We see that we can do better in terms of strength prediction than we can do with BMD, and we get estimates of breaking strength in vivo. We've applied this to the same study I showed you before on teriparatide, and we see here, for example, we can estimate stiffness. And so over the 2 years of treatment with teriparatide, we have close to 30% of increases in stiffness and actually at similar level of strength. What is also nice is you can see where are the red spots before and after treatment. Remember, the red spots reflect areas where it's most likely that fractures, microfractures occur, and then you have sort of an avalanche, and the whole vertebra is gradually collapsing. So if you look at the top left here, you see that you have a lot of red areas of great risk to fracture. And then over the course of 2 years treatment to the right over there, most of these disappear. And that is the case actually for simulating compression or bending as a function of these 2 years of teriparatide treatment. So this is a very nice example how this technique can be applied to study the effects of different types of treatment. Now, one other aspect where we have recently seen the advantage we gain with QCT and finite element analysis, it has been shown actually in a study from Tony Keaveney's group, first authored by Wang, that indeed you can predict incident vertebral fractures much better than you can do with DEXA. So again, if you see here, these are risk ratios, and DEXA actually, in this case cohort study, is on the order of a risk ratio of 3 if you measure at the spine, whereas the risk gradient is about threefold, around 10, both for QCT and finite element-based strength. So on the one hand, a very positive result. We can do much better than with DEXA. I mean, that's a huge difference. Usually you are happy if you increase your gradient from, say, 2.5 to 2.9, and everybody in the scientific community gets all excited. But this is from 3 to 10, so it's really a different world with QCT compared to DEXA for incidence of vertebral fractures. But what is a little bit disappointing that in this particular study, the finite element did not add on top of the QCT. Okay, maybe we are at the limit. Maybe we have to learn more about better finite element modeling, but certainly the bottom line is a very good result. Now, one word about radiation dose. This is much higher than with DEXA. So I've listed here a few levels of typical examinations here. So on the top you see the radiographs, the conventional radiographs that you take to study vertebral fractures. The radiation dose is on the order of 2 millisieverts. Actually, the annual natural irradiation is 2.4 millisieverts around in Europe. DEXA, we are at a level of 100 to 1,000 lower in the area of microsieverts. So this is really absolutely negligible. But then if we go down here to QCT, we are in the range of a fraction of a millisieverts to maybe 2 or 3, maybe up to 4 millisieverts, depending on whether we use the high resolution or the standard approach, whether we measure at the spine or at the hip. Now, rightfully, there's a lot of attention. Is that okay? You probably know from your clinical colleagues that there's a lot of debate about using CT. I'm not talking bone right now, but abdominal CT, cardiac CT, and the radiation levels involved in there. So one has to be cautious. So I did one thing. I took a paper that has raised a lot of attention because it calculated the risk of death, actually. A lot of assumptions in this, but let's assume this as a really worst case scenario. And there, with imaging, in our case, the bones, with QCT, there is a risk of 1 to 100,000 that by doing this examination, we risk that a patient dies. I have to say there are so many, there are so many assumptions in there that there are big error bars around this, but let's accept this for a moment. Now, if we do this to identify patients that are risk for fracturing, what is their risk to die because of a fracture? Again, we need to say, okay, what is the level of risk where we typically do these examinations? So I took some data from Germany, but I think it's approximately similar. And I calculated the associated mortality of fractures. We know all of this. And I calculated conservatively a treatment effect. And if I put all of this together, the risk reduction is on the order of 1%. So here we have a benefit-risk ratio of roughly 1,000. The risk of the radiation due to the diagnostic examination on the one hand, like 1 in 100,000, and the risk of dying from an undiagnosed vertebral fracture on the order of maybe 1%. So big error bars, but the bottom line, I think, is very clear. If we use CT carefully, not as a screening technique, but in patients at risk, I think it is absolutely ethically acceptable to use these approaches. And they are lower by a factor of 10 compared to the other CT approaches of the abdomen and of the cardiac CT I mentioned before. Okay, so much for the general approach. Now, in the second half, let me go to the specific study that shows, again, the potential on the one hand of the imaging technology and on the other hand of our new and interesting drugs. So these are reports from the EuroGeop study, which I presented this year at the ECTS. So the objective of this study was to compare the effects of 18-month treatment with teriparatide compared to risedronate. And the study group consisted of men with glucocorticoid-induced osteoporosis. The primary endpoint of this study was QCT, based on QCT, and we measured for the primary endpoint the volumetric trabecular BMD of the lumbar spine. But we also looked at a number of secondary endpoints, including high-resolution QCT, to look at BMD and microstructure, and also calculate finite element models to look at bone stiffness and strength. Of course, for reference, the typical things, DEXA, bone turnover marker, were also assessed, and of course, safety. So these were ambulatory men with low bone mass to start with, on glucocorticoid therapy more than 5 milligrams per day for more than 3 consecutive months. And they were randomized to either teriparatide or risedronate and got some calcium and vitamin D in parallel. And diagnostic assessments were done at baseline, 6 months, and 18 months with QCT and high-resolution CT bone turnover marker in addition at month 3. The analysis was based on a mixed model repeated measures design. A lot of detail here. If you have questions, I will try to answer these. This is the number of patients and how many were actually examined. So QCT results were obtained on 36 teriparatide patients and 34 on risedronate, and slightly smaller numbers, 28, for either group examined with high-resolution QCT. Actually, a lot of Spanish centers were involved in this study, and the central coordination was also done by Fernando Marin from your country. These are the baseline diagnostic, no major differences between the two treatment groups. And this is the technique that you know by now, the QCT for the primary endpoint. This is the result, the main result of this study. At 18 months, we had a highly significant difference in favor of teriparatide over risedronate. You see a high level of significance, 0.004 here, for the changes from baseline in bone mineral density of the trabecular bone. At 6 months, we could not yet see a significant difference. Then we looked at our high-resolution QCT results. So again, first the BMD, significant differences for trabecular bone and integral bone, no significant differences in the cortical bone. And then we looked at microstructure, and we got for bone surface over total volume, one significant number. BVTB was borderline significant, so good results here for the structure also of the trabecular bone, whereas on the cortical bone, we saw changes in the right direction, but they were not significant. Now, then we compared the high-resolution CT with the QCT, and the results are actually shown here on the two left bars. So you see that we get higher statistical significance with the high-res QCT approach compared to the regular QCT approach if you look at a matched sample of the same patient. So we see the increased power of this high-resolution technique also in the BMD. These are examples of images, what happens. So on the left-hand side, you see the 3 time points for teriparatide, and I think it's again visible that the density, that the structure is getting more dense, whereas with risedronate, it is more or less maintained, and you know that there's some increase in the mineralization, but not an increase in the matrix volume under a bisphosphonate treatment, such as in this case, risedronate. Then we moved on to study these same patients with finite element analysis, and this was done in a cooperation between our center and Philipp Züssit, at that time in Vienna, now in Bern. So they performed the finite element modeling, and you see here at 18 months, highly significant differences in favor of teriparatide. They studied loading in compression, these are these results, in torsion, these are these results, and in bending. And no matter how the load is impacting on the vertebral body, it's substantially stronger, or the increases in strength are substantially larger, I should say, with teriparatide than they are with the small increases you see here in comparison with risedronate treatment. The marker showed the expected pattern, no surprises there, and you see that indeed for the bone-forming markers, they increase rapidly, and they have still a significant difference towards the end. And on the right hand, you see the resorption markers. Then on the safety side, nothing major was seen here. Sorry, I apologize, the numbers are a little obscured here. But the main aspect, perhaps, of this was that there were a few patients that fractures, and all of them were in the risedronate group. These were 5 patients with, I think, a total of 11 fractures. the difference between teriparatide and risedronate was not achieved. The p-value was 0.056, and I'm sure the sponsors were not happy with that result, so close to significance, but that's life. And it was not the primary endpoint. Remember, we were only talking here about 60 or 70 patients, so I think the main thing is that we didn't see a single fracture in the teriparatide group over this time period in glucocorticoid-treated patients. So let me summarize the results of this study. In men with glucocorticoid-induced osteoporosis, teriparatide was clearly superior to risedronate. In the primary endpoint, greater increases in trabecular BMD of the lumbar spine measured by QCT, stronger improvements in vertebral bone strength, and also other biochemical measures measured based on high-resolution QCT. So the finite element was not done on QCT, but it was done on high-resolution QCT. And the analysis of the microstructure showed both with BMD and structural changes significant changes, so greater improvement in integral and trabecular bone, BMD not on the cortical end, and also the trabecular bone microstructure showed significant improvements for one measure, with another one being showing a trend. Again, no difference on the cortical structure as we measured it there. The bone formation and resorption markers showed early increases in the teriparatide group, decreases in the risedronate group as expected. We saw DEXA result as expected, greater increases in area BMD at the spinal femoral neck. And we saw a trend in the number of patients with new clinical fractures in favor of teriparatide, and no unexpected safety findings for either treatment during the course of this study. On the imaging end, I think this shows that QCT, even a very small study, shows that it is able to assess the treatment effects very sensitively. High-res QCT gave the most accurate assessment, both if you look at it visually as well as on the numerical data. It reduces the partial volume effect. It shows significant microstructural improvement and discrimination of treatment effects, and it gives you the most accurate finite element modeling because, for example, the cortical shell can be modeled more accurately. Further development are possible and are underway, so better microstructure cross-calibration, better registration, other things, so I think there's potential for further improvement. To conclude my talk, QCT status and perspective, I think site-specific fracture risk assessment requires imaging, preferably in 3D. The improvement in predictive power should incorporate both densitometry and structural measures, and perhaps down the road also measures of material properties. That depends on the treatments or the underlying disease. And QCT and high-res QCT plus finite element modeling can give you very good direct assessment of bone strength. There are some limitations. Aging, secondary osteoporosis, and skeletal disorders other than osteoporosis are not solely affected by the mineral. You have collagen changes. This has been shown, it's not yet published, but has been shown at ASBMR by Doug Bauer before, that the cross-link pattern changes, so we need to try to capture this also in vivo with imaging. Mineral measurements then may still be the main driver of fracture risk, but should be adjusted for by other techniques, and maybe that needs also be done by techniques other than QCT. Okay, with this, I'd like to thank you for your attention. I'd like to thank the many people who have contributed to this work, and I hope I could convince you that there's room for improvement and that QCT could fill that room partially, but we have to continue our research to identify patients at high risk for fractures in the best possible way. Thank you very much for inviting me. Thank you for coming here.
¿Estamos?
Aunque todo el mundo se ha portado muy bien y se ha ajustado el tiempo, como hemos empezado tarde, llevamos 10 minutos tarde. Para no afectar el break y tal, 3 preguntas cortitas y todas las dudas que tengáis las podéis preguntar personalmente a ellos en el café, cuando queráis.
Carmen Gómez Vaquero, del Hospital de Bellvitge en Barcelona. Esta pregunta es para Adolfo. La mayoría de decisiones en osteoporosis no la toman los socios de la SEIOM, la toman médicos que no son expertos en metabolismo óseo y que a veces, bueno, pueden tener o no pueden tener sentido común porque eso viene de serie. Lo que yo creo que estos médicos esperan de nosotros es que les demos instrucciones claras sobre qué actuar, sobre a quién pedir una densitometría, sobre a quién indicar un tratamiento. Yo creo que para esto el FRAX, que también tiene ventajas, no solo inconvenientes, nos puede ayudar. Y que lo que a lo mejor esta sociedad podría hacer es utilizarlo para dar indicaciones y organizar sistemas para mejorar los inconvenientes que presenta.
Sí, de acuerdo. Es mejor utilizar el FRAX que no utilizar nada, eso por descontado. Lo que pasa es que yo creo que hay que tener presente que el FRAX infraestima de manera importante el riesgo de fractura, especialmente de las fracturas no de cadera. Y en las fracturas de cadera depende un poco del estudio, pero tampoco está bien calibrado en el bajo y alto riesgo. Entonces, lo único que puede suceder es que dejemos de tratar personas de alto riesgo simplemente confiando en el FRAX, incluso con la densidad mineral ósea. Entonces, hay que tener en cuenta que eso se necesita refinar más aquí en este país.
Sí, sí, seguro, pero ¿no?
Es que si no, no acabaremos. Sí.
Felicitar a los 3 ponentes, me hace una brillante exposición. A Klaus no voy a hacerle pregunta porque es muy bonito todo, muchas gracias. Una pregunta corta, muy corta para Adolfo y una pregunta muy corta para Luis. Adolfo, las series españolas, el ECOSAP y otras que ha presentado, ¿incluían todas de BMD? Porque en América ahora BMR se habla mucho del FRAX, ha habido un revival, y aquí, como tú has dicho, acabas de decir, el FRAX infraestima en algunos casos y sobreestima en otros. Mi pregunta es si todos tenían o hay alguna serie que incluya también DEXA en su valoración. La pregunta para Luis, ¿el TBS es un sistema que está en todos los DEXAs? ¿Y está normalizado para la población española ya? Porque Ology no lo ofrece, por lo menos. Bueno, una para cada uno.
El FRAX el TBS es un sistema que está disponible, es un sistema por una compañía que lo ofrece comercialmente, una compañía francesa, y puede estar disponible para cualquier tipo de densitómetro, básicamente Ologic y General Electric. Pero no lo ofrece dentro de lo que es el paquete de software de un determinado densitómetro. Es un elemento adicionalmente que se instala como esclavo dentro del funcionamiento. Depende. Hablamos después de eso. No soy su representante comercial, pero probablemente podríamos convencerles de que hicieran un grupo hospitalario a nivel español y entonces se podría conseguir un precio mucho más abordable.
Las series de TV Cordomí de Rafa Zagra, Fridex y la serie de Barcelona, tienen BMD. ECOSAP tenía densidad calculada por ecografía de calcáneo y Canis está en estos momentos trabajando en un software que incluya densitometría de calcáneo, pero en este análisis solo había factores clínicos.
Por favor, mi pregunta va directamente para Adolfo, en el sentido de que llevamos un cierto tiempo hablando de FRAX y empieza uno un poquito, me perdonan la expresión, a cansarse de que no haya una verdadera definición de FRAX. Y cuando yo digo una verdadera definición de FRAX, me refiero que, por ejemplo, en un servicio como el mío, el servicio de necrología, en donde una buena proporción de los pacientes son diabéticos, ya hace mucho tiempo que nos dimos cuenta de que el FRAX iba mal. El diabético se cae, tiene hipoglucemias, etcétera, etcétera. Tiene tantos factores de riesgo para otra cosa que debería considerarse como un factor de riesgo principal ya en el FRAX y no lo considera de entrada. Y en eso estoy de acuerdo contigo. Entonces, ¿el FRAC infraestima a los diabéticos? No, el FRAC no vale para los diabéticos como está en este momento. Al final, como muy bien has dicho y me ha gustado mucho, como siempre, el juicio clínico es lo fundamental, número uno. Número dos, yo te quería preguntar, cuando hablas que infraestima en la población española, ¿qué factores has analizado tú? Que seguro que lo has analizado, que son la causa de que tengamos esa infraestimación. Es decir, ¿es que estamos utilizando la población de masa ósea de nanes, la americana, para la densitometría, en el caso que te preguntaba, o porque la historia de fracturas, la base de datos de fracturas que se ha metido no sea up-to-date, no sea actualizado y hay que, o cualquier otro factor. Te preguntaba para saberlo si lo has analizado, es por qué esa infraestimación comparado con los canadienses, por ejemplo. Gracias. Muchas gracias a toda la mesa que me ha gustado mucho.
Yo creo que hay un par de factores. Fundamentalmente, en el ajuste de FRACS a España es que la ratio fracturas de cadera, fracturas no de cadera es diferente que en Malmo, que fue la cohorte sobre la cual se estableció esa ratio al construir el algoritmo FRACS. Eso es explicable por el hecho de que la fractura de cadera se conoce muy bien, los datos epidemiológicos, y las fracturas no de cadera, específicamente las vertebrales, pues hay datos menos consistentes, y de otras fracturas no vertebrales no de cadera. Por lo tanto, esa sería una explicación y luego hay otras causas como genética, factores ambientales.